Hi, I'm Dr. Christina Wu. I'm an associate professor of hematology and medical oncology at Emory University, and I'm a GI medical oncologist. So the question is aspirin or any other NSAID, which is also known as non-steroidal anti-inflammatory drug, recommended for colon cancer prevention? And how do I apply the data to when I talk to my cancer patients and cancer survivors? So when I think of prevention, I think of two types of prevention. One is primary prevention and one is secondary prevention. So primary prevention is for patients who have not developed cancer and how we can prevent them from getting colon cancer. And so, if you review the NCCN guidelines, they do talk about for patients age 50, I think to age 69, who have a risk for cardiovascular disease. And they say this is a 10% risk over the 10 years for cardiovascular disease. There's a calculator where they look at your age, your sex, your ethnicity, your cholesterol level, blood pressure, diabetes, and smoking risk factors. So you have that risk that they actually do recommend a baby aspirin, which is 81 milligrams a day for cardiovascular prevention as well as colon cancer prevention. Now, I want to note, and these have to be for people who do not have GI bleeding risks. And this is a history of having any GI bleeding like heartburn and other issues who can tolerate aspirin. And so the recommendation is strictly for people who have both the cardiovascular risk factor and for cardiovascular risk factor, because they think that to take a baby aspirin alone for colon cancer prevention, the benefits may not necessarily outweigh the risks involved with GI bleeding. So that is just from a primary prevention, that if someone has some cardiovascular risk, to take a baby aspirin to prevent the chances of colon cancer and their cardiovascular complications. There was another study called the CAPP2 study, CAPP2 study for Lynch syndrome carriers. And these are for people who have not developed colon cancer. And they had randomized patients to placebo versus a very high dose of 600 milligrams of aspirin daily. And for people who carry Lynch syndrome as a hereditary trait, they did see that those who were taking aspirin did prevent the occurrence of colon cancer. Now, we don't know the data for a lower dose of aspirin of 81 milligrams of baby aspirin or a full dose aspirin of 325 milligrams. And I know that studies are being done to look at that, but this is specifically for Lynch syndrome patients who we know have a high chance of developing colon cancer to prevent that. So this is for primary prevention. So in the secondary prevention, which I think this question is more relevant to, is for patients who've already had colon cancer and have had their surgery and adjuvant chemotherapy. What is the role of aspirin or other non-steroidal anti-inflammatory drugs in that setting? In this case, if we look at the NCCN guidelines, they do talk about a baby aspirin, 81 milligrams daily for patients who've had colon cancer to prevent recurrence. Some of the data is from a large retrospective observational study reported from Norway, where they looked at patients who had colorectal cancer and had exposure or no exposure to aspirin for a long duration of time. And it did seem that patients who had exposure to aspirin had a decreased bad outcome from colon cancer recurrence. So in that, I think that is where that recommendation is coming from. I will point out that there was a large phase 3 study, it is called CALGB 80702, where patients were first randomized 3 versus 6 months of adjuvant chemotherapy, and this is for stage 3 colon cancers. But the second part of the study was actually randomizing patients to placebo, which is no active treatment, versus celecoxib, which is a COX-2 inhibitor. And recently, they have reported that patients who were getting celecoxib, after they had completed their chemotherapy, that celecoxib did not actually improve survival. So we would not recommend celecoxib in that setting. And there is an ongoing clinical trial right now throughout the states, and it's being performed through SWOG, which is a cooperative group, and the study itself is called PACES, P-A-C-E-S. And therefore, patients with high-risk adenoma, so polyps, and anywhere from stage 3 colorectal cancer. So it's for patients who've also completed, had their surgery, completed their chemoradiation, and chemotherapy, and they're randomizing patients to either placebo, which is not an active treatment, versus two drugs. One is called Sulindac and one is called eflornithine. And this study is to see if we can prevent occurrences of polyps in patients who are at high risk of this coming back. I would highly recommend patients to enroll in that clinical trial so that we may get more information about what we should be offering our patients after they've had their colorectal cancer removed.